I'm Farla Kaufman, Chair of the Public Health Advisory Board. If anybody wants to introduce themselves.
Steve Heath, I'm the other Steve.
Okay, Steve Heath, nice to see you. And Steve Orcan, past chair and past member. Libby?
Yeah, Libby Abbott, a new member of the Public Health Advisory Board.
Hi. Phil?
Yeah, my name is Phil Summers. I'm a PHAB member as well.
Hi, I'm Lori Miller. I'm the Division Manager for Substance Use Prevention and Treatment. So it's nice to be back. I used to attend this meeting several months ago, so it'd be helpful to know how our unit can be of value in this forum. So it's great to see some familiar faces.
Hi,
Good to see you, Lori.
Hi, Phil.
Hi, good afternoon. My name is Andrew Mendonza. I'm a psychologist, health program manager, also in the substance use prevention and treatment program. So over the clinical side of the house. So anything, again, as Lori echoed, anything that we can do to help advance any of the projects or any of the interventions that you're all doing, we're certainly excited to be working with you and alongside of you.
Welcome, Lori and Andrew. It's so good to have you. Really wonderful. I hope you can attend more often, and I will keep you advised of any of the meetings that have subject matter pertaining to your areas.
Great. That's the plan. Either myself or Andrew will be able to attend. Thanks so much.
Terrific. Thank you. Anyone else?
Sandy Damiano, ex officio member.
Hi, I'm Jennifer Deno. I'm the educator at Sutter Medical Center, Sacramento in the emergency department. Really excited to hear Dr. Mullen speak, and we just started our substance abuse navigator program here.
Terrific. Welcome, Jennifer.
Hi. Hi, I'm Barbie Law. I'm one of the PHAB members, and I'm having some technical difficulties today, so I'm not able to present my screen, but I am here for the audio via phone.
Thank you. Welcome.
And Olivia Kasiriamon, health officer. I will have to drop off in about 45 minutes. So to get onto another call. So my apologies.
No, thanks for joining. Okay. So let's see if we have a quorum yet. No. Okay. Yes. Okay. Liz, okay. Amy will share her screen. She has that capability later.
Yes, I'll make you co-host so that way you can share your screen.
Okay, terrific.
Thank you.
All right, so we have 12 board members. I think we need one more board member for a quorum, and hopefully somebody will join. It's kind of an odd day. Oh, 2 are excused. Well, that should be okay, right? Steve, if 2 members are excused, where did Steve go? We have a quorum, right?
If there's any question, you can hold off on votes.
Yeah. Okay. All right. Let's go back to getting started because we're cutting into our time here. So I'll just quickly go over the vacancies on the board. We still have 3 vacancies. I haven't heard from the chiefs whether we have more applicants, but I'll let you know about that. They're actively searching for members. If you know somebody who would like to serve and would be a good addition, please let me know and I'll pass it on to the chiefs of staff for the Board of Supervisors. And is there an update that either Olivia or Sandy would like to share very briefly? I'm sorry that you're not actually on the agenda, but just a quick update.
Yeah, I'll make it very quick. Just a couple of things. Our numbers have gone down slightly. Our case rate from the update from the blueprint this week was 7.5 per 100,000. We are still not making very good progress. I know everyone asks me every single day, when are we getting to orange? So hopefully we'll continue to trend downwards. The good news is that we have hit over 1 million doses of vaccine given. We still are struggling with getting vaccinations, especially in the health equity quartile. So working hard on that and working with the state. And lastly, this is our last week with Jim Hunt. So again, just wanted to publicly thank him for stepping in the midst of a pandemic and helping us to navigate during these past few months. And I've worked with him before and always appreciated him. And it was great to be able to work with him again.
It is so nice to have great staff like Olivia and her crew. And so thank you once again for your kind words. I appreciate it.
Cool. Thank you. Sandy?
Yes, I'll make mine quick too. And I want to echo everything that Olivia said about Jim Hunt. He's been a joy to work with during these months at a time, I think, when both of our divisions needed some support and encouragement and a person that knew the subject matter. So it's been great, and time went by very quickly. So we have appreciated your presence, Jim. A couple things for the emergency medical services. I just wanted to really publicly thank the Public Health Advisory Board for their letter of support. I've already heard from our EMS staff and also from Brian Jensen. They're just very grateful for Public Health Advisory Board support. That will go a long ways. And then for our WIC program, as you know, our WIC program is having a little bit of a funding reduction from a planned first 5 fiscal cliff. I've asked them to reach out to the health plans. And so far to date, they've received $55,000 from the health plans just to support their lactation program, which is about 41% of the loss. And so that's much appreciated. It's a very small amount of money, but it will make a big difference for our WIC clinics in keeping some of those lactation hours up for our lactation consultants. So it's a great program, so we really appreciate that. And then for Correctional Health, I know everybody's been very interested in COVID, so just very briefly, I saw a data snapshot on Monday that I've never seen or haven't seen in a long time. We had actually on Monday had 1 patient at the branch jail that had confirmed COVID and 0 at the main jail. So that was very unheard of during this pandemic time. So that's really a great relief for us, but our testing is still really robust. As of last Wednesday, we had done 380 more tests. So to date, we've had over 15,000 tests in process. So we're continuing to test a lot, and our total number of net confirmed last week was 4. So we're doing more testing because we're actually able to move patients from the jails to the prisons, because they're finally allowing us on a flow basis to move people over, which is really good for us. And then on the vaccination front, we, like other jails and other partners, had difficulty once the Janssen vaccine went on pause. We did do a restart, but it's hard to get that going once everyone has heard about the media. So to date, we've done, as of last Wednesday, 1,294 inmates received vaccines and 1,115 were fully vaccinated. And for our staff, as of last Wednesday, 432 staff received at least one vaccine and 408 were fully vaccinated. That doesn't count our UC Davis employees that from mental health, and it doesn't count people getting vaccinated offsite. So we're continuing to do those as well, although the numbers are pretty small at this point for the staff vaccinations. So probably it for me.
Thank you very much. Very, very good news on the COVID side. Yeah, side. Good, wonderful. Thank you. And I'd like to thank Jim Hunt too for his service. I'm so sorry that you're not able to extend that.
Well, thank you. It's been an honor to serve, and I'm not sure I'll do it again, but it's been a good experience.
Time. Sorry.
Thank you and all of our advisory board members for the work you do. It's very, very helpful. Appreciate it.
Okay. All right. So let's move on to hear from our guest speaker, Imd Mullen. And to introduce Amy, I will ask Phil Summers for his introduction.
Hi, everybody. So I want to introduce one of my longtime mentors, Dr. Imd Mullen. She's a professor of emergency medicine and psychiatry at UC Davis, also former past president of California American College of Emergency Physicians and co-director of the California Bridge program, which is expanding substance use disorder treatment to emergency departments all across the state. She's a really incredible advocate and a wonderful mentor. So anyway, without further ado, I'll let her take it from here.
Okay, thank you, Phil. I'm going to share my screen. And the other thing I'm going to have to do is apologize to you all ahead of time because you have given me an opportunity to talk about like the thing that I am most interested and passionate about. So totally apologize, but it's your fault for giving me the soapbox. So the other thing to know is I'm an emergency physician. So what I am comfortable with is chaos and interruptions. So I'm really hoping that you guys will help me to feel comfortable and interrupt me and ask questions. Because if you are quiet and listening attentively and not asking questions, I'm going to feel like something is wrong in life. So really hope that this is more of a conversation than a lecture, because that's just too much. So I am an emergency physician. I'm boarded in emergency medicine and addiction. And the way that I got there was really thinking about our patients with mental illness and kind of thinking about like how we could do a better job and what we are missing. So really, I've thought a lot about this over years. Many people are going to disagree with me. It's a little bit of a different bent. So take it for what you will, and please interrupt and challenge me on this. But really, from what I've seen is that we are missing our most vulnerable patient population. And that's kind of a recurring theme that we see over and over again. And as you kind of alluded to, we always get to this point in talking about ED boarding and how can we reduce the problem in the emergency department. And I think what we need to think about is like, how do we meet the needs of our patient population? Because it's not about the ED, it's not about the setting, it's about how do we do a better job of taking care of our patients? And to recognize, like, as we kind of alluded to before, this is not something that is going away. And we talk about this hidden pandemic. One you can see over here, this is this study from JAMA Psychiatry looking at ED visits for overdose, for mental health emergencies, child abuse and neglect, intimate partner violence. And you can kind of see like this line is our stay-at-home orders, and those visits have increased. And so we know that there's this need out there. And then the other piece, which I find really disturbing, is the overdose deaths. And what we can really see is for a long time, California was a little bit spared in terms of we were not exceeding the overdoses for the rest of the country. But we can see that that is accelerating in California, and we are now meeting and exceeding expectations in this metric. And so this data goes almost to the pandemic, and from everything we've heard, it's increasing. So we sort of know that this hole that we've dug ourselves during this past year in terms of drug treatment and mental illness is going to be deep and wide and broad. And so I think that the fact that you guys are focusing on this right now is really key, because you're exactly right. This is our next challenge. Questions before I keep moving on? Okay. And let me know if I'm not hitting your needs and what you guys want to hear about. But we're here because we kind of talk about the emergency department. And so we're going to hear about it sort of from my perspective, which may be different from how you guys think about emergency care. But really, these are the goals of any emergency department care, is we want to rapidly stabilize the acute condition. We want to provide evidence-based care. We want to be able to, and this is key, tailor our treatment options to the patient's needs and provide patient and family-centered care with dignity. We don't always achieve this, but this should always be our goal. And so what I'm talking about here, you guys know, this is parity. And I'm going to take a little bit of a digression and think about when we talk about our patients with mental illness, right? We talk about acute psychiatric crisis or a patient with an acute mental illness crisis as if they were all the same. Like every patient with a psychiatric illness has the same thing. Versus what is parity? Someone comes to me with a cardiac complaint. I don't say, oh, you are a cardiac patient and I do one thing. We triage, we have multiple options for emergent treatment, urgent treatment, outpatient treatment, stabilization. There are a lot of different options and patients have different pathways. And so that is one of those things that I think is really missing with the way that we think about acute behavioral crises. Questions here? I'm hoping to change the way that you think about this. And this is key, right? We all talk about 5150s and we talk about ED boarding and patients in the emergency department on 5150s. And the entire acute psychiatric system has been about this tool. Because a 5150 is not a diagnosis. It does not define a behavioral health emergency. It is meant to be a tool whereby someone who is not safe can be treated involuntarily. I call it hospital jail because that is what it is. It allows me to take away someone's rights to provide them treatment. Questions about this? You guys are quiet. I told you not to do that to me. But we've kind of changed and we think about the 5150 as the way you define an acute psychiatric need. And it has become the tool for emergent treatment. So the way that we think about it is completely wrong, and it is not analogous in any other way. That we really should think about this as a tool and think about the patient population, what are their needs, rather than do you need a 5150 or not? The whole system has been designed around this single tool. And I think that's kind of corrupted the way we think about emergent psychiatric care. All right, so here's our data from UC Davis. And what this is this is looking at our patients who've come in with a psychiatric evaluation. So here we are going immediately into lumping everybody with mental illness or substance use disorder, acutely intoxicated through this single pathway. And you can see this is our length of stay. The line on the bottom, that is the ED length of stay for people who got a evaluation and were not thought to meet criteria. The line on the top are for people who met criteria for a 5150 hold. These numbers are outrageously long. And so I think that's partially why we're here. But the thing to notice that I think is actually interesting is the patient population that never met criteria still has a pretty long length of stay. So even that population that has come in that doesn't meet criteria still needs care and still needs options. And I think we sometimes forget about them as we're trying to funnel everybody through this one single process. I also think what is interesting to me about this is I think that, you know, we've been struggling with this as a community for a long time. And we have, unlike, you know, popular belief, done a reasonably good job of providing some other options. We do have the urgent care center, so we do have some walk-in options. So at this point, like the population I'm seeing is actually pretty acute, as you can kind of see from these length of stays. Questions here? I know you guys have questions here.
Amy, can you hear me?
Yep.
Okay, one question is, do you have any data on the percentage of these patients who had a concomitant medical problem that would have required emergency care?
So yes and no. Let me go to the next slide and see if that answers your question. Because how do we define emergent medical care? So this is the ultimate disposition of people who met criteria for a hold. So these are the people who were placed on a hold. And only a very small percentage of them are actually admitted to the hospital. So I don't know if that, you know, if you define acute medical illness as admitted to the hospital, that's actually pretty low. But that doesn't mean that they didn't receive care in the emergency department. Almost half are discharged from our emergency department, so are seen, placed on a hold, treated in the emergency department, and then discharged. About half, a little less than half, are sent to a mental health facility, and 7.2% are transferred. That is a very heterogeneous population. Sometimes like Kaiser takes their patients back. Some of them go to a nursing home or some other facility. Also, when I look at the patients who are on a psychiatric hold, about a third are unsheltered, over half have substance use, and 16% are what we in that repeat visitor range where they have over 4 visits in 3 months. So we do have, this kind of tells me like, I am not meeting the needs of this patient population. So anytime in emergency medicine, we say, anytime someone comes back, we should take this as an opportunity to say, okay, we didn't meet their needs last time, let's do something different. Unfortunately, in this pathway, I have a hammer. It's the 5150 hold. So we tend to do the same thing over and over and over again that wasn't necessarily working.
Amy, I have a couple of comments.
Mm-hmm.
I first want to say it's always great to hear you share and speak in these forums, and we appreciate your partnership. I want to say that certainly this data is concerning, and patient care and identifying patient needs is certainly a priority. And the lengths of stay numbers are also concerning, that a person cannot be discharged or referred out to resources that may or may not be available, and their length of stay is extended. So all of this is really concerning, but I did want to share that both Andrew and I have worked in emergency department crisis units. And so we both know firsthand of the lack of resources at the county level and needed in terms of expansion and being able to meet the needs, and certainly these high numbers in terms of the data that you're presenting. If a hospital does not have their own substance use disorder unit like Kaiser does, they have their CDRP, but other hospital settings do not have that in place. So, I mean, maybe it's a good time too to speak to, this is a great conversation, and the fact that UC Davis reached out to the county, maybe speak to the fact that your emergency department is now Drug Medi-Cal certified and being able to expand your ED bridge program along with outpatient services. And we're hoping this partnership with the county is able to decrease this substance use number of 57% and get people linked more quickly into services. We certainly, have our own challenges in terms of availability of services, but we're certainly working on that to expand our continuum to meet this patient population. I do want to comment on that and just appreciate the partnership. And Andrew, if he wants to speak to his experience working in ED crisis as well, and ways that maybe we can help in this area.
I won't take time from Dr. Amy, but just wanted to again echo that definitely we both have been in the trenches. We understand how much substance abuse really affects the patients that you're seeing in the ED. And I think it's an epidemic for sure, and something that we are certainly excited to be working with you on, and hopefully to address through bridges and other programs that we have out there.
Yeah, I should say, I love that you were both here because you're stealing my thunder, because I really think that this is one of the keys, is that like, I need to address substance use in this population. Because, I'm going to go back, these numbers are outrageous, and clearly there's a need for more inpatient psychiatric care. But imagine a world without methamphetamines. I mean, imagine a world like what I kind of wonder, what would these numbers be, and what would my need for inpatient psychiatric beds be if I didn't have folks with stimulant-induced psychosis? Like, what if that population was gone? Where would these numbers be? I don't know the answer to that, but I certainly think that is a piece. Like, I'm not going to say that we wouldn't love more inpatient psychiatric beds, but I don't think that is the sum total of how we can address the needs of the population. I think one of the pieces is we need more tools. We need more options than just this 5150 tool, which has kind of become this de facto pathway. Anyone with any behavioral illness gets shoved through this single pathway, which is clearly not working for everybody. Okay, and so then I'm just going to talk a little bit. Do I have more questions on this? Because this is kind of our system. I have a little bit of slides on how we've tweaked things at UC Davis in particular. If you guys are interested, I'm going to run through some of that, and then we're going to talk about substance use, because that's near and dear to my heart. Okay, I'm going to go through this stuff just because we've made a lot of changes. We've established a behavioral health area, recognizing the environment of the emergency department is not terribly therapeutic, so that we can have this quiet, calm environment with better access to food, drink, blankets, the easy stuff, as I call it. Really that struggle of balancing patient safety and autonomy, and everything that we can do to decrease trauma. And then I always talk about increased help-seeking behavior, because every time that someone has a negative experience with healthcare will decrease the likelihood that they are seeking help later. So we want to be mindful of that, at the same time balancing patient safety and autonomy, which is always the challenge in the emergency department. So we've established a separate area that is quieter and hopefully more therapeutic for patients. But again, this is still about waiting, and this is still about 5150s, which is really just a broad hammer for what the needs are of this population. This is our current process, where we have someone comes in, they get screened for suicide, they get a social work screen, then they get medical clearance, then they get a 5150 evaluation, then later they're seen by psychiatry, and then switching this to more of a team-based real-time approach where we all come together and do all of this all at once. So certainly some of these systems that we can improve internally in terms of team-based care, but still numbers are outrageous. And so this is really what I want to think. When I look at that slide, like, what are the two needs of the population that I am seeing that we are not meeting? And that is people who are unstably housed and addressing their substance use needs. And so that was sort of where we have focused, or at least I have focused on our bridge program. And that is to provide patient navigation and treatment. We try to start treatment wherever we can in the emergency department, primarily at this point focused on opioids, because buprenorphine is really so easy and has such great evidence base behind it. So I'm going to talk about that. But all of us should know, like, stimulants are really the huge problem that's unaddressed in our community. So this is kind of the thought that we take, is meeting patients where they are, but don't leave them there. And this is something we're able to think about in terms of our substance use population. But again, I kind of struggle with this with the 5150 process, because we sort of have this one way to get patients care. And we don't necessarily have access to other options. Crisis residential, a little bit. We're not tightly linked into outpatient treatment. We are not tightly linked into full service partnerships. We sort of operate outside of the system of care that you've developed in the county. And so for me, I shove everyone through the 5150 process, when really I think we would benefit from a tighter connection to really be able to triage folks into different options. And so this is just some data on homelessness and substance use, and to kind of highlight what you all know, which is there's significantly higher rates and higher severity of substance use in our housed versus not housed population. And this is all comers, a cross-sectional study of all ED patients, looking at any drug use, the severity of their drug use. DAST kind of measures how severe their drug use are, and the history of overdose. So we have really high rates in our unstably housed population of a prior history of overdose. And so this is what we do. Some of you probably know Tommy Trevino, who is our substance use navigator at UC Davis. And he is a phenomenal human being. He's done a fantastic job of really advocating for patient needs. He goes above and beyond in trying to link people back into the community to outpatient resources. And he will provide continuity and follow up with people to make sure that they've broken down barriers and made it into care. And so by doing this, we're hoping to kind of peel off some of those patients and address their substance use needs. And so we can kind of start to stabilize and provide more options and address some of the underlying concerns. And so really, we've been amazed at how much people do want our help. For every 10 patients with opioid use disorder, 6 were started on buprenorphine and 4 actually went to follow up and engaged in care. And I just sort of want to reiterate, the patient population that I'm talking about is a third experiencing homelessness, a third have co-occurring opioid and stimulant use disorder. And when we looked at it, people experiencing homelessness who were connected to substance use treatment from the emergency department went to care more frequently than stably housed patients. So we've really become a conduit for getting people experiencing homelessness into substance use treatment. And I highlight this because I think frequently we think to ourselves, people experiencing homelessness can't connect into care. I think they have a lot of barriers. It is really hard to make a 3 o'clock appointment, but they do want treatment and they can make it into treatment. So that I always kind of come back to this of like, we talk about treatment resistance for people experiencing homelessness, but I think a lot of it is our system isn't as accepting to people experiencing homelessness. And one of the positives about the emergency department as an access point is we are always open and people know where we are. So we are easy to access. And so what we're trying to do is sort of embrace that role of, hey, we are the place that people can access care and we should see it as an opportunity to link someone into care. And then as Lori mentions, this is what I'm really excited about is we are opening up a bridge clinic to provide really low barrier access to substance use treatment. I'm hoping to really focus on people with stimulant use disorder, with methamphetamines, and to really help to support transitions of care, to really help get the folks in who have trouble transitioning into other options for care, and really have kind of this harm reduction, low barrier approach through our UC Davis Bridge Clinic.
Amy, where are you opening this at? Is that going to be on the campus, or where is this going to be
Yes,
located?
it's going to be on the campus. They've given me a little spot on the campus that I think they plan to knock down later, but I'm going to try and make it really successful so they can't.
Great. Can't wait to tour it one day.
Amy, do people have to go through a medical triage first before they're referred into the Bridge Clinic?
So we're hoping that, yeah, so my initial first plan, because I believe, like, you have to learn to crawl before you walk and walk before you run, is we're going to kind of self-refer people from the ED to our Bridge Clinic, or people that we've discharged from the inpatient center to our Bridge Clinic, and then hopefully to grow the program. My view would be that we would have walk-in capabilities if we can expand access, because I'm staffing it with a group of folks who are dual boarded in addiction, emergency medicine, and primary care. So everyone there will be kind of dual trained. And then this is just, Kazi gave me my soapbox. We all know that the elephant in the room is stigma, right? That we inherently, and everybody treats people differently because of stigma. And just to kind of think about, anytime we design a system, is this the system I would design for someone with chest pain? And frequently the answer is no. And so to think about, like, the system we have designed, partially because the way we've conflated a 5150 with treatment access, and the inherent stigma of people with mental illness and substance use, this is the elephant in the room. And so this is the kind of principle we come from, is all people deserve rapid access. So that means, like, I should see them in the emergency department. People come to the ED because they think they need help. They don't come to the ED because they want a 5150 evaluation. They think they need help. And so we should be able to provide that help, whatever it is, and do the best job to treat them with dignity. And then as we kind of talk about 5150 and hospital jail, the other sort of elephant in the room is that, substance use is a disease that's also a crime. And so we're kind of dealing with these two pathways with how we treat people and functionally take away their rights as a way to get them medical care. And so I know that's kind of, it's a big challenge and it's controversial, but I think that is the system that our patients experience. And the more we can kind of address some of those barriers and provide them care in a way that works for them, the better, and the better we'll be able to start to decrease some of those outrageously long length of stay. So I know I covered a lot, definitely gave me a chance for my soapbox. I really appreciate it, and I'm happy to answer questions.
Amy, thank you so much for that wonderful presentation and education. So if you had carte blanche and you controlled everything, except maybe that 5150, because that's sort of way up there, what would you do? How would you change it?
Yeah, so this is heresy, because everyone in my department would say we need more inpatient psychiatric beds. And we do need more inpatient psychiatric beds. But generally, like, an inpatient psychiatric bed is taking away someone's rights. And so I would like a pile of resources for housing. I would like to be able to access your full service partnerships so that I could help get folks into those wraparound services. And then if I could wave a magic wand and, get everybody into treatment for stimulant use disorder, we're going to try contingency management and some of the newer medications that have been studied. But I kind of think, what would the need in our population, in our community, for involuntary inpatient treatment be if we did not have these high rates of stimulant use disorder and people had good social support? And if when they come to me in crisis, I had access to that full spectrum of options. Does that make sense? Like crisis residential or immediate social support, if we were part of the system of care. Because right now I kind of like, I am a conduit for the 5150 rather than taking an individual, assessing their acute medical crisis and their emergent needs, trying my best to address them, plug them back into the system. And the 5150 was a tool that I used if I absolutely had to.
Amy, have you had discussions with our behavioral health director, Ryan Quist, around, behavioral health being part of this continuum and supporting you in what you're requesting here in this meeting in terms of linking people more quickly? I know that they have, wait times and it's a different process on the mental health side than it is on the substance use side. But we both have, challenges. So I just wondered if you had started a conversation at all.
No, and I think that's a good point of like, I'm sure that there is a way that we can do a better job of, tapping into, some of the full service partnerships and, outpatient options out there. So it's just, it's like the way that the system is designed does not really think about the ED in terms of like case management and full service partnerships. We're kind of outside.
Yeah, we do have quarterly meetings with other hospitals, and UC Davis is not alone in these challenges. Sutter experiences them, Kaiser, all of our managed care plans. And so I think bringing this conversation to the table with the individuals already meeting around different challenges around access to care, but I'll certainly bring it back to Ryan and start a discussion, and maybe a meeting can come out of it.
Thank you.
Yeah, I apologize. I let Ryan know a little too late about this meeting and he was already booked. But I will also bring this back to him and talk about it. And it would be a wonderful thing if we could all, not me, but all the interested parties involved could sit down and really talk about the barriers and the possible solutions and from all viewpoints and work through this. Because it does make sense to me that if you're in the system, working in the system, seeing this from ground level, that you can pass your experience and what you've put out to us, Amy, here as possible solutions to the larger entity of the county and how things happen and how things are connected. It seems like something that's not really requiring a large financial investment, which is usually a barrier. So perhaps it's a low-hanging fruit. Let's just make some better connections and better avenues to access care for your patients.
Yeah, thank you.
And I'm not saying we don't need, housing and drug treatments and
Right.
Certainly we need more resources, but I don't think that like inpatient beds is the sum total of the needs of our population.
Yeah, no, from what I hear, that is an area that people have been working on. We hear a lot about housing and a lot about the beds, and certainly that's no brainer. We do need that, but I have not heard this aspect, and it intrigues me because, as I said, it seems like it might not be that difficult a change to make that would make a big impact.
Yeah, thank you, Amy, for this presentation. Very informative, and I really applaud you for the initiative you're taking. And I would echo Lori's comments that I think getting our heads together, we might be able to come up with some solutions, or at least some approaches to try to alleviate the problems you're seeing and to help these patients.
Thank you.
This is Jen Deno at Sutter Medical Center. I really am so impressed and thrilled to see all this work being done kind of on that moving out of the ED side. But I just want to kind of put out the idea of the patients who are waiting those hours and hours to be evaluated, waiting for them to metabolize until we can actually evaluate them. oftentimes, as you know, our EDs are full and they're in a hallway with their watch person, and they're exposed to all of the sounds and chaos of an ER. And we tried at one point putting them all in one area, but then sometimes they would get each other worked up. So then we spread them out throughout our department, and it's better, but it's not ideal. And I just, as I walk through our halls most days, you know, these people are here just waiting. And if we admit them, then we lose our place to get a psych facility. So there's never been a really good plan for those people to give them a therapeutic environment.
Yep. No, totally agree. Our length of stay is outrageous. And we always say, you know, if you were not having a mental health crisis when you came into my emergency department, try spending 50 hours in a hallway. That, you know, just the insomnia alone would get you.
I agree.
So do you see other potential solutions to that problem? I know you described the separate holding area or waiting area.
Yeah, so I mean, you know, but you know, that's part of this is like, as Jennifer Deno mentioned, it's waiting, right? I mean, I just don't think, like, we need to make sure that time that we have taken away from someone, so every hour that I have that person, I am holding them in hospital jail. So they deserve the maximal efforts that I have to get them out of their hospital jail. And I know that the county made a lot of effort around, you know, crisis residential beds. And certainly I think, you know, there could be more voluntary treatment options, because not everybody I see who is waiting in my emergency department doesn't want to be there. And so, you know, we don't necessarily have access to like inpatient treatment that is voluntary, or, you know, the day programs. Because I think that there's a full spectrum of options that could help people. Inpatient detox, you know, there's a lot of other options that I think people within this population could benefit from. And we tend to put everybody through a single system. A 5150 should not be the only, currently it is your ticket to acute psychiatric care. And if you want acute psychiatric care, you have to qualify for the 5150, get your ticket, and then wait in line. And there should be other ways to access acute psychiatric care than just the 5150.
Hey, Dr. Mullen, can I quick question on the data on the homeless patients getting plugged into care? I know like that population is kind of, you know, intersectionally kind of stigmatized and subject to, you know, many social determinants of health, that I'm really curious that like increased odds ratio of engagement in care. Yep. It's like very counterintuitive, and I'm like, is that the result of like resources, or how do you explain it?
So there's an increased odds ratio of people experiencing homelessness following up with care in our opioid use treatment program at UC Davis, as well as Bridge program wide. So we saw that in our program at UC Davis, and then did a sample of about 15 of the Bridge hospitals across the state of California, and saw roughly the same odds ratio of people experiencing homelessness more likely to access care when they were referred from the emergency department. And so I think it's one of those things where we think that this population is treatment resistant, and that's just not what we're seeing in terms of treatment for opioid use disorder. That when we make it really, really easy, and we try to break through every single barrier, like fix the pharmacy problems, fix the transportation problems, do our best to contact them, set up appointments, they actually go at higher rates than people who are stably housed. And I think that's because it's sort of the only avenue. I mean, you know, that I found remarkable, because we found that at UC Davis and then Bridge program wide.
Amy, I have a quick question. Are there any racial disparities in the way people are treated regarding the 5150?
So I've looked at the breakdown, male, female, and race and ethnicity for people evaluated for 5150. And then I also looked at people that we sent over to our behavioral health area versus not. Like, were we saying that, different races were more unstable than not and gave, different races preferential treatment? And they were pretty much identical. So I was surprised at that. I don't know, within the population of the folks who were evaluated for a 5150. I don't know. We've also looked at who is given sedating medications more, like a B52, or put in restraints more. I haven't seen all of the analysis of that, but in terms of 5150 and then who we internally determine should go to the BHU, the BHA versus stay in the ED, it's like an exact match. So I was gratified by at least that.
Amy, one more thing. Some of your patients are walk-ins, but I imagine most of them are brought in either by police or by the fire department. And what I was wondering, and really the reason I asked the earlier question about medical conditions, is if you had your way with legislation and were able to direct the fire departments and police where to bring patients who are having these mental health emergencies, would you feel that they're safe enough to go to alternative places besides a medical emergency room rather than bring them to you?
It's an interesting question, because I know that they've had good pilots in terms of taking people directly to an inpatient psychiatric facility from EMS. And so I think, certainly there's a subset of population that can easily bypass the emergency department and go to an inpatient psychiatric facility. I also think, if it's kind of a catch-22. Could you bypass the ED and go directly to an inpatient psychiatric facility? Absolutely. But also, if you could go directly to an inpatient psychiatric facility, I would send you almost directly to an inpatient psychiatric facility. So it's kind of a funny question of, like, if you had endless capacity in the inpatient psychiatric hospital such that they could take people directly transferred in, I wouldn't have those outrageous hours, and it would be easy enough to come through, triage people, stabilize, discharge some, and transfer some.
Yeah, I'm talking about taking.
It's one of those, like.
Yeah, I was just asking about what about taking people directly to the crisis clinic that the county.
To the urgent care.
Mm-hmm.
So we do often we'll see folks, that we do actually refer people to the county urgent care. For me, particularly because it's functionally across the street. So we will see, like, someone who is kind of more low acuity, who is anxiety, PTSD, needs a medication refill. Most of the medication refills will just refill it, but we can refer people directly to the urgent care. So I don't know that that's a huge volume, but I'm also just directly across the street from the urgent care. So it's really easy for me to refer folks there. I don't know if that's probably not the experience of other hospitals. The truth is if someone was low acuity, it doesn't take that long for us to kind of manage and refer, particularly to the urgent care. And if there were inpatient beds that had a ton of capacity, I would use them.
Amy, let me ask you, just because I've also had work in the private psychiatric hospitalization world. And so there's often this push that they need to be medically cleared before they're referred for inpatient psych, right? In your experience, maybe you have any data on it, but do you oftentimes find that you guys are uncovering the medical condition that would have precluded them or would have made it difficult for them to receive adequate care at the psychiatric hospitals? I guess I'm saying, I oftentimes hear hospitals use that as a reason, but I wonder if there's data to kind of debunk that everyone needs medical clearance before they go to a hospital.
Right, so we do the SMART medical clearance, and we've been doing that for several years, and I think it's community-wide with a lot of success. And so it's there's a definitely a population that does not need intensive medical interventions, that's pretty easily clearable, except for substance use. I think that the way that I think actually the triage that is happening, and I don't necessarily have data on this, although I could probably pull it out. I think the actual triage that is happening is the functional wait times are trying to tease out who is intoxicated and will clear, like who is, has like acutely intoxicated and suicidal and will clear, whose acute psychosis will either resolve or be mitigated once they clear from the stimulants. And so that, I think, is why, it's not necessarily that there's a pile of people who have heart failure, COPD, diabetes that need to be stabilized. It's mostly that sort of co-occurring substance use. And I think as our wait times have gotten really long, hospitals have gotten used to patients at a different level of stability than previous to 2009, when everyone was going to SHMIC from the field. They were comfortable seeing a much more acute presentation than they are now. That's my opinion. I don't know what they would say.
Thank you. It echoes what my thinking was as well. So thank you.
Are there any other questions? Okay. Amy, thank you so much. Obviously, this was a need to educate us and some other guests, and it's been terrific. I think it's obvious that we should continue this conversation in a setting that includes all of the players involved, especially in the county, and we will attempt to make sure that happens. And I'm sure that Lori and Andrew are also on that page and have expressed that. So it would be wonderful to hear back in, let's say, a month or two, that things are shifting and moving, and these changes that could be incorporated possibly will be making a difference. So
I really thank you all. Appreciate your time, and appreciate you giving me my soapbox, because it's something I care deeply about. So thank you.
It is great to hear somebody who's so passionate about their work, really, and for such an underserved population and a very, very difficult, entrenched problem. So we appreciate your coming very, very much and hearing this. Lori and Andrew, I'm sorry for not extending an invitation in advance, but now that you are here, I hope that this is going to continue. And as I said earlier, I'll make sure that you're kept aware of all our agenda items that could possibly pertain to your area.
Absolutely.
Yeah, if at some point we can have a standing agenda item just to provide substance use prevention and treatment updates, I think it would add value to this group, as we at times have, working on similar initiatives or their substances across the board. So we would certainly want to be of support to the board.
Thank you. I'm glad for that suggestion, and we would welcome periodic updates. That would be terrific. I'll make sure I reach out to you and we'll follow up on that. Thank you again. Okay, as we move on, it seems like we now have, a quorum, so I will just return to a brief bit of business. We had 2 draft meetings that were sent out, meeting minutes from April. We had 2 meetings early on April 3rd, and then a special meeting on April 21st. Those minutes were circulated, and I would like to call for a motion to accept We'll start with April 3rd's meeting. Is there a motion to accept those minutes, or are there any changes to those? Let me preface that. No, no changes. Are there any motions to accept the minutes? Do we still have people on? Oh, Lori. No. Thank you.
Farla, it's Barbie. I lost the Zoom connection completely, so now I'm only on the phone and trying to get back into Zoom.
I am so sorry. Well, good to have you back, at least on the phone.
Yeah.
So we are trying to vote on the meeting minutes. And I know that I've gotten a number of excusals. So we have very few members right now on the phone, but I think we can vote with them. Let me see, we lost a few. 1, 2, 3, 4. You know what? I'm going to postpone the acceptance of these minutes until next meeting. We'll just push it, and we'll leave the draft meeting minutes posted on the website. Okay, let's move on. Referring to the April 21st meeting that we had, it was a special meeting regarding correctional health. And there were a number of decisions, well, at least one, to set up a working committee, because PHAB has an extreme interest in this area. We've heard from quite a few public organizations. Decarcerate Sacramento has come and talked with PHAB, and a number of public comments were offered. We had a special meeting where we heard from Correctional Health, we heard from the Sheriff's Department, we heard from these community groups and individuals in the community. And so it has become apparent that this is such a complex issue that we as a board, as a full board, it's not very feasible to be addressing the entirety of this by our once-a-month meetings. So a working committee would enable a smaller group to be more nimble without having to post notices and all the other requirements of the Brown Act. As a committee, they could have latitude to speak with a number of individuals, a number of entities involved in this complex issue. And so PHAB has the capability to form a working committee, and that would entail 9 members at max. At least we have 12 members on the board, so we could have 5 board members, and we could have 4 community members from the public. And I know there are people who have expressed interest in being on the committee, being some of our board members, some who are present right now. And then we could put it out to the community that there are vacant positions for 4 other members. The purview for this committee would be set by the committee. Obviously, the concern is correctional health in its many, many aspects. We would certainly ask that they be present at this board. I know at this committee, Sandy Damiano, I'm sure would provide a wealth of information and just a tremendous perspective on this. So I'm hoping that Sandy, you will also be willing to participate. Right now, of the people, I know Libby, you expressed interest, and I think Phil and So can I put your names down? Great.
Yes, please.
And I will put it out to the board, the broader board. I'm not sure. Maybe Sonal had mentioned it, but when we have all of our members back, I'm sure you'll get more participation. Does anybody have any comments about this?
This is Sandy. I, of course, have a comment. So right now, part of our workload is so heightened, it's almost unbearable because we're doing all of this work with the monitoring with all of the experts and our plaintiffs' counsel. So for me, participation would depend on, exactly, what the committee is wanting, because I don't know that we can duplicate the work we're doing institutionally, the work we're doing with all of our monitoring, and then another set of guidance. So hopefully it would dovetail, because we can't do another whole set of work and just because of our bandwidth, not from desire, but bandwidth.
No, absolutely. Totally understandable. And I think that that would be very doable. Perhaps the committee could ask for you to send materials that you feel are important for them to have in terms of providing a background to this issue. And I know there are a lot of them. And then perhaps they could come back with questions to you that you could answer and not have to be participating all the time. I do understand that you have an amazing amount of work and burden. Any other comments about it? I know last time you Sandy mentioned starting with the consent decree and the remedial plan.
Well, what I mentioned was that when we were asked to present before, it was just on the COVID. So that was very limited viewpoint of what the work was in that one little sphere. So in order for anyone to know, just like I answered all those questions that I received on the letter, I think at the special meeting, I think people need some framework for what's involved in the remedial plan. Otherwise, it's very difficult.
Yeah. Yeah, I think it would be a steep learning curve to get familiar with all the various aspects of this complex issue. Not to mention the consent decree and the COVID situation. There is now a call for an oversight committee for the jail population under the sheriff's purview. This is not part of, wouldn't necessarily be part of the working committee, but that's another aspect to be considered. Okay.
A separate group.
Yeah. Okay, Phil and Libby, would you like to set up some kind of timetable for meeting? Would you be comfortable sort of getting the ball rolling? I'm not going to say chairperson of that committee, but perhaps you can sort of put out a call, or I can put out a call, but the scheduling would, more be up to you and the rest of the committee.
Yeah, perhaps Libby and I can coordinate, and we can maybe send out an email to the rest of the group, people that aren't present, and see who else is interested, and kind of develop a quorum, and then based on that we can figure out a time to follow up and kind of meet separately and figure out a game plan and kind of what our scope is. I don't know, whatever other ideas you have, Libby.
I think that sounds like a good starting point, and maybe even sort of going through what Dr. Damiano's already given us and building our own kind of learning framework, Dr. Damiano, so that we're catching ourselves up to speed as much as possible before pulling on you. And then would it be Liz, would we work with you to do the communication to the community to invite members into the working group?
Liz could definitely play that role. Yeah. So that would work. Okay, you think that, so maybe within the next 2 weeks, we'll have an idea of who's interested and materials for the committee to begin with. Okay, great. All right, and you can decide on a name to come later. All right, wonderful. Next item. Not sure Sonal is in the middle of budget planning preparations. It's that busy time of year, and I know she's sort of hopping on and off this. Oh, there we are. Hi.
Hi, Farla.
Thank you so much for taking the time, and you can make it as brief as you'd like, because I know you're busy.
No, I apologize. It is possibly one of our more busier times right now as we're working towards the May revision. What I can do, I just want to note that I could be called off at any second, but let me just start sharing, and worst case, I will provide a quick follow-up note to the group with some more details on the conversation. I think that might work best for us. So thank you, Farla, for making time and giving us a chance to report back on our conversation with Ryan Quist. So Farla, Phil, and I met with Ryan met with Ryan back in March to learn a little bit more about what Sac County was doing in the behavioral health world, his perspective on some forthcoming really significant funding, as well as in what ways PHAB, what else we can do to support the department's efforts. So we discussed a couple of items really specifically, including the state's infrastructure proposal, which Ryan saw as a really much needed and a positive proposal. He did share with us that Sacramento County has 3 large freestanding psychiatric inpatient hospitals. However, because all of these hospitals have more than 16 beds, they don't qualify for Medi-Cal funding. And one of the things that the state is planning on doing in the next couple of years is submitting what they're calling an Imd Waiver to CMS, which would allow the state to in turn begin billing for facilities that have greater than 16 beds. And that would really be helpful in terms of creating more infrastructure, because a lot of the facilities have way more than 16 beds, and it's sometimes a lot easier to build fewer facilities with more beds versus the opposite. We also discussed assisted outpatient treatment, which is court-ordered treatment, including medication treatment for individuals with serious mental illness. And AOT has strict legal criteria. So the individual, for instance, must have a history of medication non-compliance to be eligible for this program. This program has not been implemented in Sacramento County yet. For many years, it's been around. It's called Laura's Law. That's kind of, I think, the more colloquial name. But for many years, it's been an opt-in only program for counties. But with the passing of this legislation, it actually became an opt-out program. So counties are now required to go through the process of publicly deliberating and then commenting on why they're opting to not participate in AOT. Apologies. And Ryan pointed out a couple things. He didn't necessarily have a pro or con list, but he said there's a lot of trauma and conversations, and the idea of involuntary commitment can be really triggering and traumatizing for a lot of populations and communities out there. And he said there's a lot of people in favor of this and a lot of people opposed to this for various reasons, and he takes both sides and both sides' concerns very seriously. So, he's interested to see how this conversation proceeds at the county level, but he wanted to at least acknowledge he does really believe both sides have genuine concerns and genuine feelings about the legislation and what it would mean for Sacramento County. We talked a little bit about the CalAIM proposal, and he's very excited about the CalAIM proposal. He sees a lot of modernization coming on the behavioral health side, which he thinks will streamline the department's efforts and make it just a lot easier to get paid at the county level. He noted a couple of the components of the CalAIM proposal, namely the enhanced care management and the in lieu of services, which would allow Sacramento County to bill Medi-Cal for services that the county has already been doing using Mental Health Services Act funds. So these these programs really targeted like the highest need Medi-Cal patients. And instead of using existing county funds, they'll be allowed to bill Medi-Cal. So this will result in some county savings that could be redirected for other uses. Let's see. Broadly, we discussed behavioral health funding and sort of the impact of COVID-19. One thing that Ryan flagged for us, that while there are fewer concerns now than there were at the beginning of the pandemic about sufficient county funding to support behavioral health services, because there were concerns that we were going to be entering a recession. Now that we're learning that this recession hasn't really occurred, there are fewer concerns about us running out of money, but he did indicate that in the out years, Sacramento County is actually spending more than they're receiving. So there are some concerns about funding in the future, but as for like this year and the next year or two, we're still in good shape. And I think towards the end of the conversation, we really wanted to talk with Ryan about like, what are things that PHAB can do to support him and his department's efforts? What are things that they would like to see? And a couple of things he noted for us, namely that he would really like to see urgent care become a 24/7 option. Right now it's 10 a.m. to 10 p.m. because of a lack of funding. And he really like to see this become like an around the clock model, and to reopen the conversation about funding this program so it could become a full-time model. And then he also was really interested, given his work with the California Behavioral Health Directors Association, for which he's the treasurer, in reopening the conversation about realignment and how much each county receives from the state for this purpose. He's indicated that because of the way realignment was set up, the funding model is based on populations from several years ago, and clearly, you know, the way California is growing and changing, the methodology used several years ago doesn't quite align with what our population looks like now. So that's something that he's indicated that CBHDA and himself are both really interested in sort of bringing back to the table as we move forwards. And I think the last thing he mentioned was funding 911 alternatives, which I think our group is pretty well versed with, and we're learning a lot more about as we continue these conversations with decarcerate. And he noted that in particular, funding 911 alternatives to the emergency department is a strong interest in their group, so that we're not seeing sort of the backlog of people at the emergency department, but rather moving these individuals into actual care sites. And I think that was all I've got to share, but Phil and Farla, if you have anything you'd like to add to share with the group, I'd really appreciate it.
Totally.
Well, I think that was very comprehensive, and some of it certainly is echoed by Amy, has been echoed in our hearing her presentation. Obviously, a lot of this needs attention from both sides. We're hearing the need from the emergency department perspective and the need from the director of health services, behavioral health. So a lot of it has to do with funding, but a lot of it has to do with moving the emphasis in specific areas, and again, those connections. So hopefully this will help, and we'll continue our discussion with Ryan in the future. So that was terrific. Liz has her hand up.
Hi there. Just wanted to note that I know Dr. K isn't on, but Dr. K, Linan, who I think had to hop off too, and I have also been in conversations about CalAIM's impact on public health and how some of those enhanced, in lieu of services, enhanced care management might also intersect with some of the work that public health does. So it's kind of in a learning phase now, but there's a lot of opportunity there.
Terrific. More partners, more connections, different connections. Good. Any other comments or questions? Okay.
Carl, I would just say, this is Lori. In addition to what Ryan mentioned about how PHAB can support the division, I would say on the substance use side, we're certainly working on building out our system and, you know, decreasing or increasing access to care, decreasing barriers of people getting into care. And so I think the discussions around what it's going to take to ensure that people get care on demand moving forward versus these longer wait times that we're currently experiencing.
Lori, so I think it would really help PHAB, obviously, to have a better understanding from your perspective and the county's perspective. Would you come next month and help us understand another piece of this in a bigger picture?
Certainly, I can come, and then I would like to have Andrew attend on a regular basis. And I think just kind of talking about the substance use system and giving you an overview, because it's been quite some time that a representative from my unit has attended these meetings on a regular basis. But there was a time where we provided regular updates and spoke to how sometimes our services connect in various ways in the initiatives that we're working on both the public health side and the substance use side. So, yeah, I'll certainly, I'm open, definitely. Thank you.
Thank you. I will send you an email. And Andrew, thank you very much. All right.
Farla, can you hear me okay, Farla? It's
yes,
Barbie.
I can, Barbie. Hi.
I just wanted to make one comment about alternate destination, and I've heard some comments about, fire departments and police departments bringing these types of patients to the emergency room. And I think it's important to note that we're bound by our local county protocols, the paramedics are, and EMTs. And currently in this county, we don't have an alternate destination policy that would allow us to transport a patient to anywhere other than an emergency room. So there's challenges there as well. And so to have a complete conversation about some of these issues, I think we want to make sure that we include perhaps the EMS agency on this, because that's who's responsible for drafting of some of these protocols. And there are challenges at the state level as far as our scope of practice. And then when we look at Sacramento County, I know Brian Jensen gave his presentation to us last month from the emergency medical advisory groups. But in order to have alternate destination policies in your EMS plan, you have to have an emergency medical care committee in your county, and we don't have that right now. So there's some other challenges too. I think this is a pretty large scope problem that's going to take a multidisciplinary approach to completely resolve.
Very interesting. Thank you for that. Okay, so perhaps Barbie, we can talk and I
Sure.
can understand this better and perhaps find a way through this. Maybe, as you say, it needs to be elevated up to the state in terms of what we can and can't do. But I'd love to hear your thoughts on the way through this.
Absolutely.
This is Jennifer Deno. I'm part of the Emergency Nursing Association, and I was the Government Affairs Chair last year. There was a bill that would allow counties to do this. It didn't say you had to, because there are great pilot programs throughout the state, one of them being like a detox center, some of them directing right to mental health services. It didn't pass at the state level, but you could still do it in your county, if you had those services. So I'd be happy to share any information from that.
Jen, I think we're talking about the same thing. In my, if you read through that, it does require the county to have an EMCC, which Sacramento County currently does not have.
Right.
Which was one of the reasons that EMAG was formed, was because we didn't have that ability. So.
Yeah, I'm on EMAG too. And
oh, okay.
Yeah, so I know we really need the EMCC, and then there's an advisory group to the EMAG group, and we presented a white paper to the the County Board of Supervisors about a month or two ago about.
I know, I'm on that group too.
Oh, great. Okay. So yeah, I'd love to see all that stuff move forward.
Is there an easy way to set up a committee?
If Sandy's still on, I can't speak to what some of the challenges were to actually having the full committee. It would be a body more similar to PHAB that reports to the Board of Supervisors, if I have that understanding correctly. If Sandy's here, she might be able to speak to that more.
I think Sandy had to leave. But okay, I will follow up with a few people to see what would be necessary and what it would be entailed in setting up a committee.
Okay.
But I will talk to you, Barb, and Jennifer, thank you for being here and helping us out through this, understanding the situation. That's great. Any other comments, public comments? We're about 2 minutes left for public comments, and since, nope, no comments. Okay, so I'm going to adjourn this meeting. I think it's been an excellent meeting. I've learned a tremendous amount, and we have a number of efforts underway now between the working committee and now possibly looking into this issue for EMS. So very productive. I wish you a good month, and I look forward to seeing you next month.
Bye, good to see you.